an honor to be here. And I do agree, Florence is one of the most beautiful cities. Okay, my disclosures. Okay, so today I'm going to talk about preoperative radiation therapy and innovative radiation techniques. So first off, what are some of the advantages of preoperative radiation? So it does enable us to downstage to allow breast conservation therapy, and also helps facilitate breast reconstruction. We'll talk about this a little bit more. And also in the setting of when partial breast irradiation, and also in the setting when somebody has a recurrence, if you're doing like partial breast irradiation in the preoperative setting, it may make reirradiation in the future a little bit easier. It also can allow us to aid in translational research because we can see how the tumor responds and obtain biopsies before surgery and with other systemic agents in concurrent or sequential radiation therapy. And then also potentially reduce delays in local therapy from wound healing, such as breast reconstruction. So some of the disadvantages is that it can possibly delay systemic therapy depending on if you're doing it concurrently or sequentially. This is an example of a patient that had breast reconstruction, and if we were to use normal breast tangents in this situation, it would be very difficult for us to do without irradiating the contralateral breast, which would be unnecessary in this situation. So doing preoperative radiation in this setting would help us to not irradiate unnecessary tissue. So how effective is pre-op radiation alone for locally advanced breast cancer? So one of the trials one of the studies that we were able to find was a 32-year follow-up on preoperative radiation in locally advanced breast cancer. And this was a study that was taken between 1970 to 1984 from Gustavi Russi Center. And they radiated essentially comprehensively, and did modified radical mastectomy 1 month later. These were initially all T2 to T4 patients, or N2, so very advanced stage, and 22% of them were triple negative. And the local regional controlled disease-free survival and overall survival was 89, 30, and 30%. So the PCR rates in this setting without systemic therapy was about 10% for all patients, but it was much higher in the triple negative cohort, and it was 26%. And when you look at the post-op complication rates at 30 days, grade 2 or higher was 19%, with 4% of those being grade 3 skin necrosis and 4% grade 2 or greater dehiscence of the suture. So I think that this kind of sets the stage as what can preoperative radiation do for us alone, and where do we go from here? So the next 3 slides are very busy slides, but this is from a review, and they very nicely summarize all of the preoperative chemoradiation slides. And I'm going to give some generalizations of what these slides are showing. So the majority of these slides of these trials are all basically phase 1 or phase 2 clinical trials, and all locally advanced stage 2 and 3 breast cancer patients. Pretty much they are all pretty small studies. And the radiation doses range from comprehensive conventional to slightly hypofractionated. The chemotherapy regimens range from anything from paclitaxel, mitomycin, 5-FU, gemcitabine, vinorelbine, and anastrozole. So the majority of time to interval to surgery is about 4 to 8 weeks after the preoperative chemoradiation therapy. And the path CR rates range anywhere from about 6% to about 40% in these various trials. And you can see there's a variation of the disease-free overall survival. And here's just a list of more of the slides, of more of the trials, which I won't be able to go over, but they have been summarized for us. So I'm going to just highlight a couple of those trials that were on that list. So the first one is one that was published in the JCO in 2003. This is a preoperative twice-weekly paclitaxel with concurrent radiation therapy, followed by surgery and postoperative doxorubicin-based chemotherapy. It was for locally advanced breast cancer. It's a phase 1-2 trial. And essentially the dose of radiation was 45 gray and 25 fractions, the modified radical mastectomy was about 2 weeks after chemotherapy or skin recovery after the concurrent chemoradiation. And the post-surgical complication rate in this trial was 14%, with the most common side effect being dermatitis, and about 3 out of the 44 patients had a confluent grade 3 dermatitis. The overall clinical response rate to this paclitaxel preoperative radiation therapy was 91%, and the total path, or the path CR, was 16% for a complete response. But if you include the near complete response, that was an additional 18%, taking it to 34%. So they concluded that this was a feasible and effective primary treatment for locally advanced breast cancer. The table on the bottom left-hand corner shows how quickly these patients were able to have surgery. And you can see that this was intended to be about 2 weeks to have surgery, but some of these patient plans were actually postponed all the way up to 20 weeks. In those patients that were postponed because of the skin recovery, they did allow escalating doses of paclitaxel, and they found that that did not increase the rate of pathologic CR rates. So the phase 2 portion of this was important because this was the first phase 2, this was the first trial, prospective trial, that actually showed that PCR correlates for pre-op radiation and chemotherapy with longer disease-free and overall survival in the neoadjuvant chemoradiation in the arena. So in this portion of the trial, the overall PCR rate was 54%, and it was up to 34%, and in the hormone negative, it was up to 54%. And they concluded that single agent neoadjuvant chemo-RT compares to PCR and outcomes for polychemo neoadjuvant therapy. They also ran different survival curves for disease-free survival and overall survival by PCR, and you can see that in the red lines, the PCR rates and the disease-free and overall survival was higher. And on the right side, the disease-free survival and overall survival was stratified by PCR and also hormone receptor, so triple negative. So even if they were triple negative and they had a high path CR, their disease-free and overall survival was very high. They also very interestingly found on their pre and post-op biopsies that there was overexpression of MAP2 on microarray analysis, and that also correlated with path CR as well as DEFA expression in the triple negative variants on the proteomic analysis. Okay, so moving along, another trial that I'd like to highlight is a pre-op XRT and 5FU trial. And this was, again, for locally advanced breast cancer, and followed by modified radical mastectomy and 50.4 gray of radiation, and then 4 cycles of doxorubicin-based chemotherapy. Median follow-up for this trial was 60 months, with a 5-year overall survival for the entire group of 72%. Again, these were for locally advanced breast cancer patients. So this study showed a path CR or near complete path CR of 32%, and they found that a lack of overexpression of P53 protein was associated with pathologic response rates here. And again, this study also showed that a pathologic response to the regimen has a better disease-free and overall survival, similar to the other trials. So there was a retrospective cohort of 315 patients that got preoperative chemoradiation in locally advanced breast cancer by Matuchek et al. In 2012. The chemotherapy was done either sequentially or concurrently. And again, PCR was an independent predictor for improved overall survival. And the total PCR rate in this multivariate analysis was 29.2%. And they were able to convert node positive to node negative patients in 56% of the cohort, but did have a harder time getting PCRs in larger tumors such as T3, T4. And they also found that there was an increased probability of PCR with surgery times greater than 2 months. So a lot of the trials that we just discussed are all using comprehensive radiation therapy to the chest wall and the lymphatics. This was, to my knowledge, the first trial utilizing an SBRT approach to a much smaller area. So they were using a boost dose to the primary tumor alone. So Bondau et al. And they were using this on the CyberKnife with concurrent, they were doing it with docetaxel and FEC treatments. And this was a phase 1 dose escalation trial where they were utilizing radiation in 3 fractions. And you can see the different doses that they were using here. What they found was that the total PCR rate for the entire cohort was 36%, but in dose level 3, which was the 25.5 gray in 3 fraction, there was a 67% path CR rate. All of these patients did get adjuvant whole breast radiation after the initial chemo and boost radiation upfront doses. So they concluded that for current trial or for future trials, PCR rates did not increase past dose level 3, and that we should be potentially considering a dose regimen of 25.5 gray in 3 fractions for future trials. And they also did not reach maximum tolerated dose up to the 31.5 gray in 3 fraction level. But this does point out that perhaps maybe we don't need to be treating comprehensively in the preoperative setting, and maybe we can reduce our volumes, which would then potentially reduce toxicities. Okay, so what are those toxicities? So this is a multivariate analysis of 77,000 patients. The data is from the American College of Surgeons National Surgical Quality Improvement Program, prospective registry from 2005 to 2011. And they basically broke these patients down to patients that are getting mastectomy alone, in the blue text right there, and on the right side, those that also got immediate breast reconstruction after the mastectomy. In the mastectomy alone group, there was on the, let me see, do I have a pointer here? I don't think I do. But on the very first column, the patients that got the neoadjuvant radiation therapy, they had a 9.4% experience of morbidity, whereas the ones that did not receive neoadjuvant radiation had 11.1% morbidity. Going under the green columns, the ones that had immediate breast reconstruction and had neoadjuvant radiation therapy had 14.7% morbidity versus the ones that did not have neoadjuvant radiation, it was 11.2%. So based off of this multivariate analysis, this study concluded that neoadjuvant radiation in the setting of mastectomy only or breast reconstruction, I believe the chemotherapy was given in an adjuvant setting, did not increase higher 30-day post-operative complications with or without immediate breast reconstruction. Again, with the chemotherapy being in the adjuvant setting. So this is a little bit conflicting to some of the other evidence that we have currently. Most of the other evidence is smaller single institution studies, and most of these are in the setting of breast reconstruction. So Chang et al. Reported on 41 patients that had significantly higher rates of native skin flap compromise. Selber et al. Had a higher incidence of seroma among 500 transverse rectus abdominis myocutaneous flap patients. And essentially, like the conclusion here is that the pre-op radiation reports variable complication rates ranging from 14 to 40% in reconstruction patients, roughly like at the 30-day time point, especially when it's done in conjunction with breast reconstruction. So to summarize the first part of my talk, what are some of the lessons that we have learned from the summary of the pre-op chemoradiation trials that we have to date? So we have several phase 2 trials that include different chemo regimens, which I've outlined earlier. The PCR rates range from 16 to 34% for these pre-op chemo XRT combos for all tumor types, but they are higher for the triple-negative breast cancer subtype. We do have increased skin toxicity primarily with pre-op chemoradiation, which can delay surgery, but this likely does not impact outcome. And single-agent neoadjuvant chemoradiation compares in outcomes to neoadjuvant polychemotherapy when done with radiation. And we have learned that PCR with neoadjuvant chemoradiation correlates with improved disease-free and overall survival. And it is controversial if there is a higher postoperative morbidity after preoperative radiation, especially in the immediate breast reconstruction patients. And then there's a lot of promise to seeing or finding biomarkers that may predict PCR in subtypes of breast cancer, but obviously there's a lot more work to be done in this setting. So what are some of the future studies that are needed? We still really need to define long-term morbidity of the neoadjuvant chemoradiation in the sequential and concurrent setting. We still need future randomized prospective studies to compare local regional control and survival between neoadjuvant and adjuvant radiation. And also we really need to define our fields of radiation, because perhaps an SBRT boost rather than an entire chest wall nodal field radiation could be sufficient in the pre-op setting, especially with immunotherapy and then various other systemic agents. So I'm going to kind of switch gears and try to talk a little bit about immunotherapy with preoperative radiation therapy. So most people here know that breast cancer is considered an immunologically cold tumor. However, that may not be the case for triple negative, HER2, or luminal B-type breast cancers. And radiation can induce both an innate immune signaling, which is non-specific, which then can also activate an adaptive immune signaling response, which is more specific. So what are some controversies in optimizing radiation to boost systemic immune response in breast cancer? So first is the radiation technique. We've talked about just very conventional 3D techniques, which radiate a lot of tissue, versus SBRT, or using heavy ions like protons or carbon. The volume of radiation treatment, entire tumor versus partial primary tumor radiation, and then the sequencing of immunotherapy before, concurrent, or after, and also the dose of radiation and the fractionation. So this review article by Demaria et al. Had an interesting take of kind of basically classifying radiation with immunotherapy into 3 categories based on the crosstalk between the tumor and the immune system. So in the first category, they talk about an ablative regimen, where it is basically a 1, 3, or 5 fraction of high dose radiation, immunoablative radiation, which really has the tendency to kill the tumor, but also can kill the surrounding or the vasculature within the tumor and then the surrounding kind of normal tissue. The other category is more of a subablative radiation technique, which is more of an immunomodulation technique with doses of 8 gray times 3 or 6 gray times 5. And then lastly, they talked about a very interesting category, which is mostly just in preclinical mouse models at this point, but I thought it was useful to bring it up for this meeting, called tumor microenvironment modulating radiation. And this is a hybrid between the 2 approaches that we just mentioned. So essentially what they do in this technique, what they did in the mice models, is they treated ablative techniques to the primary tumor, and then they radiated like the entire lung if they felt like the lung was going to be at high risk for metastasis. And they did this with this very low dose of radiation of 0.5 gray times 4 fractions, and they found that there was increased disease-free survival in these mice models. Again, it hasn't been shown in humans, but something to think about. Okay, so a quick clinicaltrials.gov research on what are some of the ongoing preoperative immunoradiotherapy trials that are currently going on. You can see are mostly in the luminal B and triple negative or HER2 positive arena, and most of these are using RT concurrently with immune checkpoint inhibitors. I wanted to talk about this preclinical study that I thought is actually very important for this topic. And I think that this Markovsky et al. Has some very elegant studies, and they did basically looking at, is entire primary tumor irradiation necessary? So basically, instead of treating the entire primary tumor, irradiating 50% of the tumor, and what is the response as far as adscopal and abscopal effects? So they irradiated 67 NR murine orthotopic breast tumors to either full 100% radiation or 50% radiation to 10 gray in a single fraction. And what they found in immunocompetent mice, that partial radiation resulted in tumor responses similar to full volume radiation, in contrast to immune deficient mice where that effect was not observed. They also found that there was infiltration of CD8 cytotoxic T cells in both the irradiated and non-irradiated parts of the tumor after examination 24 hours after the 10 gray of RT, and this was also shown on immunofluorescence. The second study that they did in the same manuscript was they had bilateral breast carcinoma tumors in these mice, and the right-sided tumors got hemi-radiation to the tumor, or they got total irradiation to the tumor of 10 or 20 gray, and then they looked at the response at the contralateral breast tumor outside of the radiation field, and you can see the growth curves on the right side. And what they found was that in the mice that had hemiirradiation of the tumor, it generated a significant abscopal effect in the contralateral tumor, and also obviously an adscopal effect. So again, kind of coming back to the point of, what are the appropriate volumes that we really need to be focusing on, especially if we're going to be doing preoperative radiation with chemo or immunotherapy in the preoperative setting. The same concept was looked at in humans, and this was a phase 1 study of pembrolizumab plus multi-site SBRT in metastatic solid tumors. But for tumors that were greater than 65 cc's, they utilized a partial SBRT tumor approach. And these doses were variations, and they range from 30 to 50 gray in 3 to 5 fractions. And essentially, the main highlight of this study is that there was no difference in response or tumor control between patients with largely partially irradiated tumors versus small fully radiated tumors. I'm going to talk about some innovative radiation techniques, kind of as the last part of my session. So we've talked a little bit about some partial tumor irradiation. So two techniques that have been emerging are grid radiation and lattice radiation therapy. And basically what this is, the grid radiation is a 2D therapy treatment where you have different beams that come in a 2D array to treat a tumor, versus the lattice is a 3D array. So this has been mostly used in very large tumors where toxicity, doing kind of like an SBRT approach in toxicity, may prove to be too toxic. So this is another way of getting high doses of radiation to a very large volume, which we normally would not treat like over a 5-centimeter tumor with an SBRT technique. The other advantage of this technique is that it is hypothesized that these beams of radiation can actually modulate the microenvironment and host the immune system, while you're getting some cell death and releasing the cancer antigens and activating immune cell activation, while still preserving the vascular system in the surrounding tissue that is not getting the full dose of radiation. So here you can see in the green, that's what a conventional radiation treatment would look like. It's kind of more of a homogeneous dose throughout the tumor bed, whereas with the lattice radiation, you get kind of more hot and cold spots. So where are we as far as this coming into clinical use? The review of literature at this point shows an acceptable safety profile, but this is mostly just case reports and not large trials. Particle therapy consideration when we're doing preoperative chemo rads, perhaps there may be some instances where protons or some of the heavy particles, they have a lot less dose, sharper dose fall off, so they're not irradiating a lot of surrounding tissue, which can maybe help with toxicity, and also to reduce exposure to infiltrating effector immune cells in breast tissue and circulating blood cells. And then another innovative technique is called flash radiation therapy. And so flash radiation therapy is basically giving the same dose of radiation therapy, but at a dose rate of 1,000 times higher. So the treatment would be given in like milliseconds. And this has been shown to reduce toxicity in preclinical studies of flash irradiated mice. And this really has been shown in mouse brain for neurocognition, mouse intestines, cat and pig skin. And there was recently the first clinical trial study in humans at the University of Cincinnati called FAST-01. That was a study for bone metastasis at 40 gray per second. And that was, it was a small trial, but it's the first human trial that was recently just published in the last 2 years. And there's another one called FAST-02 that is undergoing for bone mets in the thorax. Again, FLASH today is still in a safety phase, but I think something that we should consider and look out for. The last technique that I wanted to talk about, innovative techniques, is a technique that is pioneered by my chairman, Dr. Timmerman, and it's called pulsar. And basically what it is giving pulses of radiation with systemic agents. And we do this like once a week or once every 30 days. And basically what this allows us to do, if we do the treatments, 3 to 4 weeks, is it allows the tumor to shrink, and then we can do an adaptive radiation plan for the second time around. And then it also helps in not irradiating all of the immune effector cells that may be coming into the radiation field. So we can really pulse and tailor the pulses and plan for each patient and how the tumor is responding in real time. And these are just some quick examples of a pulsar treatment for some brain patients, a brain patient. And you can just see the response here over time. So what are some conclusions of this talk? So advances in radiotherapy can be used synergistically with other modalities to improve toxicity, local control, survival, and drive biology in cancer care. However, we need to foster opportunities to personalize therapy and maximize radiation as a tool in medicine. We need to drive biology and make decisions based off of the biology. So preoperative radiation can afford us this, and we should also be exploring different radiation techniques rather than just the standard conventional techniques that we have always utilized. So thank you very much.